Morning, good afternoon, good evening. Thank you very much for the invitation to give these lectures. It's great seeing some of you, and certainly I haven't seen Dr. Poland now for a couple of years, and wonderful to at least see his face on the screen. I'm hoping that sometime in the future we will see each other personally again. So the title of my lecture is Intestinal Injury in Preterm Infants, NEC and its Imposters. So this is my disclosure statement. I have no conflicts of interest. And over the next 25 or so minutes, I'm going to give you a little historical background. We'll talk a little bit about definition of necrotizing enterocolitis. Are there imposters? How can we differentiate these? Then we'll talk a little bit about the pathophysiology of what one might consider classic necrotizing enterocolitis. And then we'll talk a little bit about the neonatologists causing intestinal injury in preterms, and then go to the future. So let's start here. Here we have this little preterm baby. I'll show you a picture of this baby before, mechanical ventilation, 26, 27 weeks gestational age. And after a couple of weeks, this baby develops this very distended abdomen. Obviously, this baby is very sick and has developed necrotizing enterocolitis. And many of these babies either die from this disease or develop significant morbidities. Unfortunately, from a historical perspective, we have not made much progress in this disease. Well, one of the reasons may be because we are saving smaller and smaller babies, but at the same time, even the larger babies, we still see a lot of necrotizing enterocolitis. And why have we not made very much progress? Well, here are some possible reasons. The first is that we don't have a good definition of this disease. And I can tell you a few years ago, I was doing an examination, a PhD examination on a PhD student from Hong Kong, and she did some work on biomarkers with Dr. P.C. Ng in Hong Kong, look for necrotizing enterocolitis. And I asked her what the definition of necrotizing enterocolitis was. And I thought that that was a very simple question. But then I realized that she had trouble with it, and I had trouble with defining necrotizing enterocolitis. So we really don't have a good definition, and we'll talk about that. We lump several diseases called NEC into the same data set. We have animal models that really don't represent the disease that we see in human preterms. And we also, in many of our studies, have a narrow focus on individual pathways rather than systems. So for example, there are studies that are being done looking at toll-like receptor 4. That's one individual pathway, but there are several interactive pathways that are going on at the same time in the development of these gut injuries in these babies. And so this, I think, has actually not helped us that tremendously. So what about defining necrotizing enterocolitis? Here's a paper that was published in Pediatric Research just last year. And I want to show you the abstract, and here I have highlighted a portion of this abstract. And let me read this to you. In this review, we summarize 8 current definitions of necrotizing enterocolitis and explore similarities and differences in clinical signs and radiographic features included within these definitions, as well as their limitations. So here they're talking about 8 different definitions of necrotizing enterocolitis. What does this mean for the data sets that we have available to us in terms of retrospective and observational studies of necrotizing enterocolitis if we don't know how to really define this disease? Now, let me go back to the late 1970s, and a pediatric surgeon by the name of Dr. Martin Bell in Kansas developed these criteria, these staging criteria for necrotizing enterocolitis, stages 1, 2, and 3. And these have been modified throughout the years. But for the most part, I think we are at the point of saying that these are no longer relevant. Why? Well, stage 1 is so nonspecific, and we see what we would consider stage 1 in so many of our extremely low birth weight infants that a large majority of them would actually be classified as having stage 1. In other words, having some apnea and bradycardia, abdominal distension, showing systemic signs of not tolerating their feedings very well. So many of those babies would have be classified as having stage 1. But there is no intestinal necrosis involved. Stage 2 is medical necrotizing enterocolitis that relies largely on radiographic signs such as pneumatosis intestinalis. But I'll talk about this and how these radiographic signs can be fuzzy. Stage 3 usually is considered to be a surgical form of necrotizing enterocolitis, which you have an antecedent free air on the radiograph. But that could signify intestinal necrosis or spontaneous intestinal perforation. And we are recognizing that spontaneous intestinal perforation and intestinal necrosis are not necessarily the same thing. What do many surgeons do? They put it in a drain rather than look at the intestine. So we don't know if those babies actually have spontaneous intestinal perforation or necrosis of the intestine. So these different stages are no longer very useful. So here are some of the imposters of necrotizing enterocolitis, and I put stage 1, 2, and 3 at the very top. Here is cardiogenic ischemia. What if a baby has interrupted aortic arch, hypoplastic left ventricle? Those are all diseases where you have lack of blood flow, where you can have a lack of blood flow to the intestine, and that causes ischemia. That's a very different disease entity than what we consider to be classic necrotizing enterocolitis, and it should not be given that name. It should have a different name, such as cardiogenic ischemia of the intestine. Then we have some variants of food protein intolerance enterocolitis syndrome, which I'll talk about. Spontaneous intestinal perforations, misrepresentation of pneumatosis with placement of drain and babies who might have spontaneous intestinal perforation versus actual necrosis of the intestine. And then you have several different congenital bowel abnormalities that can cause pneumatosis intestinalis or gut injury, such as Hirschsprung's, intussusception. And you heard earlier today, CMV can be a cause of intestinal necrosis. So these are all potential imposters. Now here, let me show you a picture, a radiograph of a baby who was 29 weeks gestation. The abdomen was soft. The baby was taking NG feedings very well, but it was decided to do a radiograph on this baby for an unrelated reason, that something that had nothing to do with the bowel. Well, the radiologist looked at this and sent a report back saying that there appears to be this bubbly area in the right upper quadrant that might represent pneumatosis intestinalis, cannot rule out necrotizing enterocolitis. So what do we do as neonatologists? Even though this baby had no symptoms, we see this X-ray report and we get very concerned. And many neonatologists would do several things. Number one, place this baby NPO for 7 days, start antibiotics, put in a tube to suction. Well, this baby had the X-ray repeated a couple hours later and it was negative. And then we considered the possibility that this might actually be just stool, or sometimes affectionately called pupatosis rather than pneumatosis. Here we have another X-ray, and obviously something is going wrong here. This is a 5-day-old baby who's on breast milk, getting hydrocortisone for hypotension, and suddenly develops this distended abdomen. And here we see pneumoperitoneum. Well, this baby was taken to surgery, and here's what they found. This little hole in the ileum, but no necrosis of the bowel. This is spontaneous intestinal perforation. And if this baby had not been taken to surgery and would have had a drain placed, this baby would probably have been coded with the ICD-10 code as having necrotizing enterocolitis. We really don't have good differentiating ICD-10 codes for these different forms of intestinal injury. A few years ago, one of my pediatric GI colleagues and I wrote this paper on NEC or FPIES, food protein induced enterocolitis syndrome. And we saw a series of babies who had bloody stools. And we looked at them very closely, did physical examinations, looked at their C-reactive proteins. And some of these babies we started feeding early, but we reintroduced a different kind of a feeding, a highly hydrolyzed formula in these babies. And that seemed to improve the symptoms in these babies. So these babies were considered to have food protein induced enterocolitis syndrome rather than necrotizing enterocolitis. Unfortunately, we still do not have good biomarkers to be able to separate intestinal necrosis from food protein induced enterocolitis. Now, about 10 years ago, Dr. Alan Walker and I wrote this review article in the New England Journal of Medicine. And here's a picture from that New England Journal of Medicine article. And here is what we described in that article as classic necrotizing enterocolitis. Now in 2021, I actually wonder if we have a true classic necrotizing enterocolitis. But here what we have is a baby with a very distended abdomen, umbilical erythema. On X-ray, we see linear pneumatosis, and here we see portal venous gas. This baby never perforated, but started getting worsening lactic acidosis, thrombocytopenia, leukopenia, and was looking worse. And so the pediatric surgeons decided to operate, and here's what was seen at operation. This area of necrosis. That was taken out, and the baby fortunately did quite well after that. But this is what was considered to be classic necrotizing enterocolitis. Well, what can we say is the pathophysiology of this more classic form of necrotizing enterocolitis? We think that genetics does play a role, but GWAS studies looking at the actual sequencing really have not shown definitive sites that are highly consistent for the development of necrotizing enterocolitis. Immaturity certainly seems to play a role. The vasculature, motility, barrier dysfunction, and innate immunity seem to play a role. And also we are finding more and more that microbial dysbiosis plays a role. And I'll talk about this as one of the major factors. Now, a few years ago, a colleague by the name of Mohan Pami and I wrote a paper in Microbiome where we took sequence data, microbial sequence data, microbiome data from 8 different neonatal intensive care units and did sort of a meta-analysis on this sequence data from these 8 different neonatal intensive care units. But one of the things that we saw in the data set was something that was seen by others as well. And this is the corrected gestational age in weeks at NEC diagnosis. And we see here that most of the babies seem to cluster here around 29 to 31 weeks after birth. So that if a baby is born at 23 weeks gestation, the likelihood of that baby developing necrotizing enterocolitis in the first couple of weeks after birth is relatively low. Whereas if that baby is born at 28, 29 weeks gestation, that baby has a higher risk of developing necrotizing enterocolitis at a couple weeks. So why does this occur? Well, we think that here are some of the potential problems. Microvascular changes occur at this time. So, for example, the changes that occur in the microvasculature of the gastrointestinal tract could be very similar to what occurs in the eye. We do not see retinopathy of prematurity until approximately 31, 32 weeks, corrected gestational age. And so these microvascular changes in the gastrointestinal tract may be playing a role. An immature barrier plays a role. Toll-like receptor developmental pattern, as well as other immune factors, may play a role. We do know that at the end of the second trimester, the toll-like receptor density is very high in the gastrointestinal tract. And if you have certain microbes present that can stimulate those toll-like receptors at that particular time, you can get a perfect storm for the development of inflammation in the bowel. So let's talk about this a little bit more. These are the studies that Dr. Pami and I did, where we looked at the microbial patterns, the microbiomes of babies from 8 different neonatal intensive care units. And here we see control babies, and here we see necrotizing enterocolitis babies. And we looked at the relative abundance of certain kinds of microbes at a phylum level. And here in the control babies, we see a fairly constant level of this blue and this green. And we also see this bright yellow down here. Okay, but in the babies who develop necrotizing enterocolitis, we see this increase in the blue, a decrease in the green, and hardly any of this bright yellow. What does this mean? Well, this increase in the blue was a phylum of bacteria called the proteobacteria. The decrease in the green was a phylum of bacteria called the firmicutes. And this absence of the yellow is a phylum of bacteria called the Bacteroidetes. And here we just see this in bar graph form. So NEC was higher, the proteobacteria were higher in NEC, firmicutes lower, and Bacteroidetes lower in NEC. What does this mean? Well, the proteobacteria are the microbes that contain high levels of lipopolysaccharide in their cell walls and stimulate certain pro-inflammatory mediators, such as the toll-like receptor 4. The firmicutes are largely gram-positive microorganisms that produce short-chain fatty acids, such as acetate, propionate, and butyrate. Butyrate is a 4-carbon short-chain fatty acid that is the most important fuel for the colon. And also, butyrate holds tight junctions between epithelial cells together. Bacteroidetes is a phylum of bacteria that have a certain polysaccharide in their cell wall that stimulates the production of IL-10 and also other anti-inflammatory mediators. And here we see that in the NEC patients, this was lower. And so this is sort of setting up a perfect storm for the development of inflammation in the bowel. Now, what about some common practices that might relate to what I just talked about? And here's a cartoon by Pogo, a Pogo cartoon that says, "We have met the enemy and he is us." And I'm just going to briefly talk about antibiotics, lack of enteral feeding, and type of diet. The most commonly used pharmacologic agents in preterm babies are seen here. And at the very top is ampicillin and gentamicin. And I know that in some of the previous lectures today, there was some discussion about early use of antibiotics, ampicillin and gentamicin, for example. Commonly used, almost all premature babies, less than 32 weeks gestation, get a short course of ampicillin and gentamicin. So what might we be doing? Well, here is the non-antibiotic treated intestinal tract with a balanced microbial community. And with antibiotics, you lose a lot of the microbes, including the commensal microbes. So here we get decreased species diversity, altered toll-like receptor signaling, and immune dysregulation. Sort of similar to what I showed you in the slides where we looked at the microbes prior to the development of necrotizing enterocolitis. There are several studies, observational, retrospective studies looking at days on antibiotics and the odds ratio for the development of necrotizing enterocolitis, and this happens to be one of them. Here's 5 to 8 days. We see that the average length of treatment between 5 to 8 days, and this is the average length of treatment that we see in our very preterm babies, it increases the odds of development of necrotizing enterocolitis by 50%. But remember, this is a retrospective observational study, so there could be all kinds of confounding factors. A few years ago, we tried to get by this by doing a small pilot study called the REASON study, and this involves routine antibiotic use in symptomatic preterm neonates. And what we did in this study, we looked at 98 preterm babies, and some of these babies we could not randomize. The purpose of this was to do a randomized prospective study. Some of these babies we obviously could not randomize because there was a high risk involved with the mother having a very high fever, pus at the cervix, etc. And these babies got the routine antibiotics, but about half of the babies were randomized into getting antibiotics or not getting antibiotics. In this small group of babies, we saw no statistical difference in adverse outcomes, but it was an extremely small number. But we looked at the microbiome of these babies, and we also looked at the metabolome. And here we see a principal component analysis of the microbiomes of these. So this pink here represents this group A, okay? This represents the 2 randomized groups, and we can see a difference in the clustering of the microbes in the gastrointestinal tract, depending on the use of antibiotics or not. We also looked at some of the metabolomics, and we saw a difference in clustering. And there were some very interesting differences in gamma aminobutyric acid, the indole pathway, tryptophan pathway, with the babies who got the antibiotics. Again, this is a very small trial, and I know that Dr. Poland is involved with the study, the NANO trial that is ongoing right now, and we hope that this REASON trial, that we can also continue with this in the future. Now, what about some of the other things that we do in neonatology? In the past, we've given a lot of H2 blockers to these babies, and we stopped doing this largely based on studies like this one here. This is a multi-center study from Italy that showed that ranitidine is associated with infections, necrotizing enterocolitis, and fatal outcomes in newborns. Well, what is the mechanism of gastric acid inhibition that can cause this? Well, here's a very nice slide that relates to the microbial ecosystem that I showed you before. This is a baby who's getting IV H2 blocker, and what we see with the use of IV H2 blocker is an increase in the proteobacteria. Remember, these are the bad guys. These are the guys that have the gram-negative microbes that are gram-negative microbes, such as Klebsiella and E. coli, and low firmicutes. They stop the IV H2 blocker. Proteobacteria decreases, firmicutes increase. They decide to start H2 blockers again. Proteobacteria increase, firmicutes decrease. Again, very interesting association. What about feeding? Well, we talked about enteral feeding in my last lecture, and here we see the microbial profile in the gastrointestinal tract of babies who are getting TPN versus control. The green represents the proteobacteria, and the blue represents the firmicutes. So we see in the TPN a lot more of the proteobacteria than we see in the babies who are also being enterally fed. Again, suggesting that lack of enteral feedings promotes the growth of proteobacteria, which we saw to be associated with increased necrotizing enterocolitis in our previous studies. But associations do not prove causality. So what are some of the possible solutions? I already mentioned randomized trials might be very helpful. Very difficult to do, very expensive. I also mentioned animal models, but we really do not have a good animal model for necrotizing enterocolitis. And then we have multi-omics and artificial intelligence, which I'd like to just discuss very briefly here. Now, what about multi-omics? I'd like to start with this picture here. This is a parable, a Hindu parable, where you have 6 blind men. And these 6 blind men were asked to examine this different portion of this animal. We can see that this animal is an elephant, but they were blind men. One of the blind men went up to the side of this elephant and said, "This feels like a wall." Another blind man went to the tail and said, "This feels like a rope." The other blind man went to the tusk and says, "This feels like a spear." So you can see that all these different blind men felt something different. They got together afterward, they argued about it, but none of them came up with the fact that this was an elephant. And this is where I'd like to just mention multi-omics. If we only look at the genome, if we only look at the microbiome, if we only look at the clinical features, if we only look at the metabolomics, we may be really misled. But if we put these all together, we can develop a full network that will give us a much better idea of what is actually going on, the actual mechanisms. We can then actually identify the elephant. The problem is that this involves tremendous quantities of data, but we are now developing artificial intelligence technologies that can put all of this together. So this is where we are going in the future. We can attain precision-based approaches. I want to just give you a quick example of how we addressed SIP versus classic necrotizing enterocolitis using an artificial intelligence technique called machine learning. What we did was we looked at a large number of infants who were identified as having intestinal injury, and we looked at babies who underwent laparotomy. We saw 29 of these who actually had surgical necrotizing enterocolitis at laparotomy and 11 with spontaneous intestinal perforations. And what we did was use this machine learning technique where we trained the algorithms to look at different features. And here's some of the features that we looked at: corrected gestational age, gestational age at birth, pneumatosis intestinalis, CRP, etc. And then we did a validation group. And what we found was that using these features, we could predict with a very high likelihood of sensitivity, specificity, and area under the curve which of these babies actually had necrotizing enterocolitis or gut necrosis versus spontaneous intestinal perforation. And I think that this is a good way to potentially go in the future to really be able to differentiate the different forms of intestinal injury that we see in our preterm babies. So here, I'd like to summarize that we need better definitions and delineations of pathologies that we call necrotizing enterocolitis. In the future, we may actually be getting rid of the term necrotizing enterocolitis and have different clusters of gut injury. And once we have these different clusters of gut injury, then we can actually better target preventative and therapeutic measurements. So we need to aim toward prevention and not treatment. The intestinal microbial environment seems to be really important in the development of some of these gut injuries that we are calling necrotizing enterocolitis. And once we have a clear understanding of these different forms of gut injury, we will best be able to target preventative strategies. Thank you for your attention.